Hello, friends. So today I'm talking on this topic, respiratory failure in pregnancy. So this talk was part of a workshop that happened in National Conference in Indore as a part of obstetric workshop. So this is, as you would agree, is a big topic. So this was meant to be a 20-minute talk, but I'm sure the overview will go beyond that, considering this topic can be quite huge. So the disclaimer is it's just an overview on basic tenets and insights into obstetric intensive care. And maybe it is really hard to cover each and every aspect of respiratory failure. So just give you an overview on types of respiratory failure that can happen. So I would just say that it is more like a chocho bath or a bisibile bath. So it's more like a mixture of a lot of things. So that's about the prelude. So the topics that I would cover is most importantly, whenever we talk about anything in pregnancy, we need to be aware of all the physiological changes that happen in pregnancy. And unless and until we understand this aspect, the management would be very similar or the approach would be very similar to non-pregnant. So the key differentiating factor that determines as to how this respiratory failure or any other pathology is distinctly different in pregnancy is the physiological changes that has bearing on any disease that occurs in pregnancy. That is something which we all need to be aware. And we'll look briefly into causes of respiratory failure in pregnancy. And whenever we talk about respiratory failure, it won't be complete unless we talk about all the airway issues that arises in pregnancy, which is very unique to this, and we need to be cognizant of that. So we'll touch briefly on to the pulmonary edema aspect in pregnancy, because this is something very distinctively they are at a much higher risk of developing pulmonary edema. Talk about pneumonia, ARDS, and more pregnancy related amniotic fluid embolism and venous thromboembolism, and general management principles and role of NIV as an adjunct to physiological derangements and take home. So these are the topics that I'll try to cover in 20 minutes. So when you look at all the physiological changes that happen in pregnancy, so I've just put it into two sets, the parameters which tends to increase in pregnancy and the variables that tend to decrease in pregnancy. The variables that increase in pregnancy is the total blood volume, and heart rate increases, cardiac output increases, obviously to compensate for the fetus that would be growing, and the stroke volume increases. So these are the cardiac variables that increases in pregnancy. And respiratory variables that increases, there is increase in the minute ventilation, there's increase in the respiratory, there'll be little tachypneic. So PO2 increases, tidal volume increases, and oxygen consumption increases. And the variables that decrease in pregnancy is albumin decreases, bicarbonate decreases, blood pressure tends to decrease a little bit, your systemic vascular resistance decreases, and there is decrease in the oncotic pressure, there's decrease in the hematocrit. And since they are little tachypneic, there'll be mild reduction in the PCO2. So these are some of the variables that tends to decrease. And SVR, systemic vascular resistance, also decreases. So this is just to figuratively keep in mind that there are certain variables that increase, there are certain variables that decrease. If you look at the, just remember the decrease, I think CO2 because the tachypneic, and SVR decreases, and some of the metabolic parameters. And oxygen consumption is shown to increase from 20 to 50% in pregnancy. That needs to be kept in mind. The reason being when we are dealing with the airway or when we are intubating a pregnant lady, we need to be aware about the oxygen reserves, and oxygen consumption is profoundly high. And that has a bearing on sort of desaturation that occurs in pregnancy, and one needs to be aware of that. So we look briefly into changes in thorax. So because of the progesterone levels which are higher, so it is shown that there is 30% increase in the minute ventilation in pregnant ladies. And because of there is increase in the minute ventilation, there's increase in the tidal volume that tends to happen. And the thorax diameter, the anteroposterior diameter and transverse diameter, both increases in pregnancy. And diaphragm is elevated, about 4 to 5 centimeters, it is elevated in pregnant. And this is again a pictorial representation. There's increase in the respiratory drive, which makes them little tachypneic, and carbon dioxide comes down. And there is airway edema that happens in pregnant ladies. And there is 50% widening of the costophrenic angle that happens. And functional residual capacity decreases by 10 to 25%. If there is a large fetus, the fetus pushes the diaphragm above, and there would be reduction in FRC and the push in diaphragm happens 4 to 5 centimeters, and that has a bearing on your lung reserves. And all these changes is shown to peak in 37 weeks. And all these parameters which changes as a part of normal physiology in pregnancy, it takes about 6 months to normalize after delivery. So these are the physiological changes one need to keep in mind. So when we talk about respiratory failure in pregnancy, just about the epidemiology, 0.2 to 0.4% of the deliveries that happen tends to get admitted in ICU from the epidemiological standpoint. And out of these, 40 to 50% of the patients who deliver in ICU can have respiratory failure, and which amounts to 1 to 2 per thousand deliveries. And 1% of ICU admissions in obstetric sort of a domain can have respiratory failure. And when these patients, when the obstetric patients come to ICU with a respiratory failure, we need to understand their reserves are compromised and they are at a much higher risk of developing metabolic acidosis, because as you saw, their bicarbonate as a physiological change tends to be low. So they are at a higher risk of developing metabolic acidosis. And there will be a precipitous drop in oxygen because of the changes that happen in the thorax. You saw the FRC comes down. So, and there are changes in the diameters of the thorax, and the pregnancy itself moves the diaphragm up. All this leads to precipitous drop in oxygen, and they can very rapidly have an increase in carbon dioxide and acidosis. So this is something which can happen very acutely, because the compensation for high carbon dioxide will not happen because of the pre-existing or propensity of them having metabolic acidosis. The compensatory mechanisms will be terribly impaired in pregnancy. So the normal compensation you would expect in a non-pregnant not necessarily may happen in pregnancy that easily. So that is something we need to keep in mind. So when we look at causes of respiratory failure in pregnancy, there is pregnancy specific causes. And one of the dreaded and devastating complication is amniotic fluid embolism. Just pictorially, I'm showing that fetal antigen entering the blood vessels or amniotic vessels can cause amniotic fluid embolism. Preeclampsia, very distinctly part of pregnancy, and pulmonary edema, which we'll talk about. There are certain conditions which are aggravated by pregnancy, which is venous thromboembolism, sepsis. They are at a much higher risk of developing sepsis, and they're at a much higher risk of developing ARDS and peripartum cardiomyopathy and cardiac failure. So these are some things which are related to pregnancy and can be aggravated by pregnancy. So the other causes are asthma and other conditions which may happen in pregnancy, or neuromuscular disease, or Guillain-Barré syndrome, so on and so forth. So in this talk, I'll try to focus more on pregnancy specific. I'll talk a bit on amniotic fluid embolism, bit on preeclampsia. Pulmonary edema will focus as to why they're at higher risk, maybe venous thromboembolism and pneumonia a little bit. So if there is these other causes, these are obstetric emergencies that happen in pregnancy, and most of them will have, as you would agree, some respiratory component. You can remember this by BU CHOPS. B is for bleeding, and if they're bled extensively, they do get short of breath. E stands for embolism. A is anesthetic related cause of respiratory failure, and uterine atony and postpartum hemorrhage, they do become short of breath. Cardiac causes, it can be pre-existing cardiac cause complicated in pregnancy, or it can be peripartum or pregnancy-related cardiomyopathy. And hypertension, preeclampsia, they can also have respiratory issues. O stands for others, and P is placenta previa or abruptio placentia. So this is the BU CHOPS, which is a defined acronym to remember all the causes of obstetric emergencies, which can lead to respiratory issues in pregnancy, and S stands for sepsis. So when we talk about respiratory failure, it won't be complete unless we talk about the airway issues. And obviously, when they have severe respiratory, we intubate. So one needs to bear in mind the difficult intubation incidence or prevalence is much higher in pregnancy. As you see, 64 in 1,000 as compared to 45 per 1,000. And the failed intubation risk also is much higher, 1 in 750 or 0.13 to 0.35% as compared to normal, where it is 1 in 2,000 as opposed to 1 in 280. So the risk, so your possibility of a situation having where you are unable to intubate is much higher in pregnancy, and the risk of aspiration also is very high. So why is all this high? Because in pregnancy, the stomach moves upwards and there is reduction in the esophageal sphincter, and there is increase in the angulation. So the residual volume in the stomach increases, the pH of the stomach contents also increase, and the pressure within the stomach also increase. And there is placental gastrin, which tends to increase hydrogen concentration within the stomach. So all this leads to them having much higher risk of aspiration and the deleterious effects post aspiration. And even your gastric emptying also is delayed. So these are some of the reasons why they are at a much higher risk of pulmonary aspiration. So during airway management, so one needs to have increased experience, especially when you're dealing with the airway in pregnancy, because airway, as I said, there'll be a lot of airway edema. There can be a lot of mucosal ulceration, and the mucosa is very friable, and there is increased difficulty. And any failed intubation situation will have has a direct bearing on increased morbidity and mortality. And studies have shown that they desaturate very fast. As I said, there will be a precipitous drop in oxygen, increase in carbon dioxide with failed metabolic compensation because of whatever physiological changes. And it is shown that there is increase in the shunt fraction from 2 to 5% to 12.8 to 15.3% in pregnancy. And FRC is low, oxygen consumption is high, and increase in the intra-abdominal pressure. All this makes the intubation more challenging and difficult in pregnancy. And it is recommended or suggested that one should not take more than 15 seconds to intubate in pregnancy, because the more delay, the more precipitous drop in oxygen and the deleterious effects. And even the big breaths also come in the way of handling the laryngoscope in pregnant ladies. So all this needs to be kept in mind when we are dealing with intubation and airway in pregnancy. So that's in brief, because we cannot move forward in respiratory failure without addressing the concerns that one should have while intubating, jumping and intubating these pregnant ladies. And pulmonary edema, and there are different causes for pulmonary edema. The tocolytics that one use with beta-adrenergic agonists increases the risk. So if there are more than 2 tocolytics used, it increases the risk of them having pulmonary edema. And this, along with any infection, significantly increases the risk of them developing pulmonary edema. And preeclampsia, by virtue of the pathophysiological changes that happens, pushes them at a high risk for developing pulmonary edema. And peripartum cardiomyopathy. So in preeclampsia, they tend to have sort of a vasodilation and tachycardia, which puts effect on the cardiac component, putting them at a risk of developing pulmonary edema. And in that, there will be activation of antidiuretic hormone with increased retention of sodium and water, which also puts them at a higher risk of developing pulmonary edema. And this, along with any fluid resuscitation that is happening, pushes them at a higher risk of them developing pulmonary edema. And in preeclampsia, it is shown that the oncotic pressure, plasma oncotic pressure, tends to come down, which leads to a lot of capillary leakage that happens in preeclampsia, which pushes them to have pulmonary edema. And there is increase in the pulmonary capillary hydrostatic pressure, which again pushes them at a risk of pulmonary edema because of the fluid movement within the alveolar space. So this is some of the changes that happen with concomitant usage of tocolytics and in preeclampsia, which pushes them or puts them at a higher risk of developing pulmonary edema. So vasodilation and tachycardia having an effect, and ADH activation leading to increased fluid and water retention, and significant capillary leakage with reduction in oncotic pressure that happens in preeclampsia, and hydrostatic pressure, which increases, pushing the fluid into the alveolar space. So this is in essence as to the changes that tends to push them into pulmonary edema in pregnancy. So just briefly about peripartum cardiomyopathy. So the risk of peripartum cardiomyopathy, mortality is put at around 19% in pregnant lady. And the heart failure tends to happen in last month or within 5 months after postpartum. That is when they are at a much higher risk of developing peripartum cardiomyopathy and heart failure. And we call it as peripartum cardiomyopathy when there is no other cause of heart failure in pregnancy, or there is no past medical history of them having any cardiac condition. So it tends to happen in the last month, and 5 months postpartum is when your peripartum cardiomyopathy happens. If someone has had a pre-existing cardiac condition, the symptomology or complications happen in the second trimester and not in the last month or 5 months postpartum. So we call it as pericardium cardiomyopathy when you have a LV dysfunction with ejection fraction less than 50% or fractional shortening less than 30%. So, and this also needs to be kept in mind in pregnant ladies who tend to have respiratory failure. So what about pneumonia in pregnancy? So it is shown that respiratory failure secondary to pneumonia is the third leading cause of obstetric patients needing intubation and mechanical ventilation. Around 12% of the pregnant ladies who come with respiratory failure in ICU tend to end up on ventilator. And preterm birth can tend to happen in 1/3 of these patients who have pneumonia, which leads to increase in the infant mortality rate. And there are certain obstetric patients who are at an increased risk of pneumonia, especially the ones with the comorbidities like obesity or who have diabetes, asthma, and this pregnant respiratory failure is possibly secondary to high risk of them having viral pneumonias. So there is this data which comes from 2009 flu epidemic in US, where it is shown that the risk of pregnant patients when they get pneumonia of needing hospitalization goes up by 7-fold if they tend to develop pneumonia in pregnancy. So one needs to be aware that pregnancy and pneumonia is not a good thing because they tend to get sicker, and then their tendency or their propensity to get admitted to hospital goes up by 7-fold, and they are at a 7-fold higher risk of developing severe respiratory failure or severe pneumonia. So pneumonia in pregnancy is really bad because the risk very exponentially increases, needing hospitalization or severity. So this was the US data in 2009 flu epidemic, where they looked at 788 obstetric patients who developed pneumonia. 65% of them needed hospitalization for pneumonia, and 16.25% of the patients had severe sort of a respiratory failure, and 13% ended up on a ventilator needing intubation. So it is suggested when we are dealing with viral pneumonia or influenza or a flu, early initiation of oseltamivir less than 48 hours has shown to lessen the severity of the disease in pregnancy. So this is in brief about pneumonia. So pneumonia in pregnancy is bad because it does increase the risk of needing hospitalization, and the risk of severity and needing ventilation also tends to increase, adding to morbidity and mortality. We look into the ARDS. Pregnant ladies are at a much higher risk of developing ARDS, so they are more vulnerable. And the reasons for this, we have looked into it. The oncotic pressure tends to come down, and they have more capillary leakage, and they have reduced albumin. All this pushes them at a much higher risk of developing ARDS. As I said, the oncotic pressure comes down, your total blood volume increases, your hydrostatic pressure, pulmonary hydrostatic pressure comes down. All this pushes fluid into the alveoli, which increases the risk of ARDS. And there is upregulation of the cytokine storm that tends to happen, which also pushes them at a higher risk of ARDS. So that's in brief about the different components as to why pneumonia is bad in pregnancy, which leads to respiratory failure, and the risk factors for them at a higher risk of being developing pulmonary edema and ARDS. So amniotic fluid embolism, as I said, is very unique or very distinctive to pregnancy-related complication. First recognized in 1926 by Mayer and reported in 1941. And it is shown as one of the 5 leading causes of direct maternal death. And when they looked at the data of US and Europe, 2 in 100,000 deliveries can develop amniotic fluid embolism. And study by Frati et al. Showed it is 5.5 per 100,000, 1 lakh deliveries. So if you look at the case fatality rate in amniotic fluid embolism, this is the Italian data, 24.8% was the case fatality. And this was another study by Busardo where they showed 12.8%. So there are unique risk factors as to who are the obstetric patients who are at a higher risk of developing amniotic fluid. Age more than 35 years, multiparous lady, someone who has a preeclampsia, and all the uterine causes, someone who's had a uterine rupture, who's had an abruptio placenta, placenta previa, and the gravid uterus with a male child are at a higher risk of developing amniotic fluid embolism. Someone having cervical tear, instrumentation, and circlage removal. So all these are some of the uterine causes which pushes someone at a higher risk for developing amniotic fluid embolism. So what is the pathogenesis of amniotic fluid? As the name sounds, amniotic fluid enters the maternal circulation, and the fetal antigen is highly antigenic. So it leads to activation of the whole cytokines. And because the amniotic fluid enters the maternal circulation, there is activation of cytokines that happens, and there is release of all these toxic variables like arachidonic acid, endotoxins, and interleukins, platelet activating factor, TNF alpha, and there are a lot of pro-inflammatory cytokines that get released. And all this cytokine storm and the release of all these inflammatory mediators lead to three components. One is cardiac component, respiratory component, and coagulation component. So it can lead to severe vasoconstriction and bronchospasm, and there is activation of the whole coagulation. So these are the three important components of amniotic fluid embolism. So one is the cardiovascular manifestations, respiratory manifestations, and coagulation cascade activation. And there is activation of complement also leading to reduction in the C3, C4. And the whole pathognomonic sort of changes happen are similar to septic shock and anaphylactic shock. And there is a lot of mast cell degranulation also that tends to happen. So this is just pictorially showing as to the changes. So just for us to recall, it is just the activation of the whole inflammatory cascade that happens, leading to respiratory, cardiac, and coagulation manifestations. So clinical features, it is a devastating complications. Patients will have acute collapse, so they can have seizures and they can get confused. In cardiovascularly, they will have arrhythmias, collapse, and they'll have direct cardiac arrest with profound hypotension. It's like a massive pulmonary thromboembolism. Respiratory, they can develop bronchospasm, respiratory distress, and ARDS. And coagulopathy, they develop coagulopathy and multi-organ dysfunction. On transesophageal echo, they have shown that patients do develop severe RV dysfunction, pulmonary artery hypertension, later on leading to LV dysfunction. And local uterine, as I said, there are a lot of local causes like uterine rupture, placenta previa, instrumentation. All this can lead to postpartum hemorrhage, cervical tears, so on and so forth. So the Tsunami et al. From Japan has categorized the manifestation of amniotic fluid embolism into three variants: classic type, anaphylactic type, and DIC. Classic type is predominantly the respiratory manifestations where they have hypoxemia, respiratory distress, and ARDS. Anaphylactic, predominantly they'll have cardiac, where they'll have arrhythmias, cardiovascular collapse, and cardiac arrest. DIC, they'll have coagulopathy. So very simple to remember. These are the three components of amniotic fluid embolism, and all this lead to increase in the mortality. So this is the criteria they have laid out. So laboratory tests, there are few laboratory tests. So they have looked at monoclonal antibodies against this antigen called Sialyl-TN antigen, which is very specific to amniotic fluid embolism. And this antigen is present in the meconium and amniotic fluid. They have looked at zinc corpoporphyrin level 1, which tends to level significantly go up in tests done by liquid chromatography. Complements come down because we saw there is activation of complements. And they have looked at amniotic fluid, interleukin 6 and 8, and tumor necrosis, which tends to go up. And there is increase in the interferon gamma fetal beta protein 1. So these are all some of the academic interest, but many a times we may not get too much time to establish diagnosis based on this. It will be more clinical, where they'll have cardiovascular collapse and respiratory manifestation and coagulopathy. So these are more of an academic interest, that some of these antigens tend to go up, and this is to confirm that amniotic fluid embolism has set in. So management of amniotic, as I said, it's a devastating hyperacute condition where immediate airway breathing circulation has to be established, and all these general measures of improving the maternal circulation by putting them on left lateral and displacing the uterus to improve the IVC flow, so on and so forth, and cardiac arrest has to be activated, and all the resuscitative measures, and at the same time looking at the 5H and 5Ts in a cardiac arrest has to be looked into. So these are all general principles as to how you would approach any sort of an acute crisis where cardiovascular collapse happens, has to be put in place. And it is shown that the best survival happens when there is perimortem cesarean section that should happen within 5 minutes when a diagnosis of amniotic fluid embolism is contemplated. So child has to be delivered within 5 minutes to save the mother. So that is the key important thing that one needs to bear in mind. Hemodynamic optimization, every intensivist would be very familiar. Fluid optimization, vasopressors, connecting them to all the invasive parameters. And sometimes there is a peripartum cardiac arrest. Sometimes extreme option of IABP, ECMO, and CPB has to be considered. And if there are local postpartum hemorrhage and other coagulopathy that has set in, so transfusion of blood products at 1:1:1 has to be looked into. Local management of these with endovascular sort of embolization or even surgical measures to attain hemostasis, and use of all these oxytocin and other agents to attain hemostasis has to be considered. So the key thing for us to recognize is the survival of the fetus is dependent on survival of mother. So mother takes precedence. So whole efforts should be to save the mother and expel the fetus to save the mother. And there has to be a good sort of a coordination between, it's a multidisciplinary team approach. So good coordination between obstetrician, emergency physician, anesthesia, intensivist, neonatologist, all this has to happen in tandem. So that's about AFP, which typically happens in pregnancy as a cause of respiratory failure. Very quickly, we'll run into pulmonary thromboembolism, one of the leading cause of maternal mortality. So the occurrence rate is around 1.08 per 100,000. So risk factors are same as amniotic fluid embolism, obesity, BMI more than 30%, and someone who's had a previous risk factor, smoking more than 35 years, who had a previous history of venous thromboembolism, thrombophilic states, having heart failure or having respiratory failure, COPD, and having inflammatory bowel disease or malignancy. All of these general causes which increases the risk of someone developing thromboembolism applies to pregnancy also, or someone having invasive catheters, and someone who has hyperemesis, ovarian hyperstimulation, and someone who's had a long flight for more than 4 hours. So these are all the general risk factors for venous thromboembolism for any individual, applies for pregnancy as well. And pregnancy specific is same as amniotic fluid. So all this we have gone through. So the virtuous triad, where there is stasis and instrumentation and prothrombotic state, increases the risk. And venous thromboembolism risk occurs throughout the pregnancy, from the first trimester to the third trimester, the risk happens, but half of them tend to occur after 20 weeks. And as you see, the DVT is the most prevalent, 75 to 80%. Pelvic vein thrombosis happen in 10 to 12%, and pulmonary thromboembolism, 75 to 80% of these who have DVT, of which 20 to 25% can develop pulmonary thromboembolism. And risk increases by 20-fold in 12 weeks postnatal. So even after postpartum, they are at a risk of developing venous thromboembolism. And first 3 weeks carries the higher risk. And it is shown that left lower limb DVT is more common in pregnancy than the right. So 90% happens on the left lower limb and 55% in the right. And iliofemoral also occurs more commonly, 72% versus 9%. So these are some of the epidemiological data. Just for us to remember, the risk happens equivocally in all trimesters, but after 20 weeks, the risk is much higher. Left lower limb DVT is more commoner, and risk increases 20-fold even up to 12 weeks postnatal. So one needs to keep this in mind. So diagnosis is by clinical ultrasound, and if ultrasound is negative, if there is no suspicion, then no need for treatment. But if there is increased suspicion, even with a duplex ultrasound being negative, ultrasound has to be repeated at day 3 and day 7. There is something called left rule, where you measure the calf of the left lower left leg. And if the left leg calf circumference is more than or equal to 2 centimeters of the right, then the suspicion of them having venous thromboembolism would be much higher in first trimester. So D-dimer has no role. Chest X-ray to rule out any pathology. CTPA is the gold standard. And ECG, 40% of them show features of thromboembolism. So treatment of venous thromboembolism is low molecular weight heparin. It has to be given for 3 months, and it has to be continued 6 weeks postnatal, because the risk of them increases to 20-fold postpartum. So we need to continue 6 weeks postnatal. And if they have recurrent PTE, can happen in 1 to 15% of the patients. And newer oral anticoagulants to be avoided in pregnancy. If they have heparin-induced thrombocytopenia, fondaparinux has to be used. So additional therapy like sequential calf compression can be used if there is a contraindication for low molecular weight heparin. So graded compression stockings compared to placebo has shown to be of no use. So graded compression stockings is something that one should not consider as a standard of care. So if there is a contraindication for low molecular, then graded compression stockings with sequential cough compression is something that needs to be considered. So as a desperate measure, if any of these cannot be used, one should consider inferior IVC filters has to be considered. So just last couple of slides, the physiological rationale or benefit of NIV. So NIV helps in mitigating the shunt fraction. As you see, shunt is a situation where you have a good perfusion of the lungs, but some of the alveoli are not ventilated. So NIV can circumvent shunt fraction. And there can be ventilation perfusion mismatch where ventilation is happening, but perfusion is not happening. So even here, some, the optimization of this has to happen. And there can be diffusion impairment where NIV may be beneficial. And there can be ventilation perfusion mismatch due to microthrombi. So these are some of the causes which has to be addressed as a cause of respiratory failure. And for shunt, definitely before NIV and after NIV, there will be significant improvement in the shunt fraction. And we have understood in pregnancy, there is significant shunt component that exists even without any pathology. So NIV tends to be beneficial in improving the shunt fraction and improving the ventilation perfusion mismatch. And hypoventilation disorders, also NIV is helpful. And in situations where there is reduced minute ventilation, NIV can be beneficial. So general management principles of risk factors in obstetrics. So just to have this data in mind, 0.2 to 0.5% of the obstetric patients may need ICU, and intensivist role becomes very important in addressing the cause of respiratory failure in these patients. And it has to be in consultation with a team effort. By sometimes if there is peripartum cardiomyopathy, cardiologist's role may be important, or if there is a coagulopathy or postpartum hemorrhage, the role of hematologist become important, and rheumatologist's role may be important in some of the APLA or other conditions that we may be dealing with, and dietitians and clinical pharmacy also becomes important. Again, reiterating, survival of the fetus is very much dependent on the survival of mother. So the whole focus should be on putting efforts and attempts to save the mother, and then worry about the fetus, and multidisciplinary team approach is what is needed. And saturation in pregnancy has to be maintained more than 95%, and PaO2, it is desirable to maintain more than 70 millimeter mercury. Carbon dioxide, PCO2 less than 25 has shown to cause fetal hypoxemia and fetal acidosis. So like the general principles of managing respiratory failure with oxygen devices apply for pregnancy, from mask oxygen to HFNO to rebreathing mask to HFNO to NIV and then to intubation. And one obviously need to be fully aware about the difficulties while intubating these patients, and all due diligence has to be exercised, and all the gear, difficult intubation gear has to be kept in place when one is contemplating on intubating and ventilating these patients. So that's about it. It's a very exhaustive narrative on respiratory failure. So just gave you an overview. So as an intensivist, we need to be aware about certain causes which are very unique to pregnancy and very distinctive to pregnancy. So you can visit my website, www.drpradeeprangappa.com, to read to this. So thank you, one and all.